the end of the day that I have to go through and report. And I've been doing that since the year 2014. And it makes around 30,000 OCTs that I've personally written and signed myself. So मेरे से अक्सर लोग पूछते हैं कि आपको इतनी OCT कैसे आती है, and my reply always is कि इतनी अगर किसी गधे को भी दिखा दोगे OCTs तो वो भी सीख जाता है. But the good of it, I guess, is that when you do something repeatedly and you do something for so long, then things that are not mentioned in the book start to come to light, and you begin to pick up signs and from the OCT as it may occur, or if you're a surgeon, then you pick up certain tips and smallest maneuver of the hand that helps you in your surgery, which has not been explained or described by anybody else. And that is really when the fun begins in whatever you do. So I was hoping for a lot of juniors to be here, but it feels like so that मैं थोड़ा सा टेकी से बात करती, लेकिन आप लोगों के सामने सब एक नई student बन जाऊँगी. I'm sure I'm going to come out of this by learning a lot. But just to go over the thing that the OCT is marvelous, right? So superimpose मैंने की हुई है वो histology वाली diagram है जो हमें फर्स्ट ईयर मेडिकल कॉलेज में सिखाई जाती थी और हमें उसकी डायग्राम बनानी होती थी. एंड डे इन एंड डे आउट वी यूज्ड टू सी दिस एंड वी फॉरगेट दैट दिस वाज अ कैडावरिक सैंपल and we were seeing it under a microscope. And now our patient comes and sits in front of us, and within 5 seconds we've got down to the histological layers. We have in vivo view of the retinal layers. So not only is this a marvel of biomechanical engineering, but also it has revolutionized our understanding of the retina. So from maybe, would be, could be, I think it is objective evaluation. We've gone to subjective evaluation, we've gone to objective evaluation of the retina, and we are now rethinking our disease processes and rethinking our guidelines for treatment. So that's amazing. So the common question in busy OCT is अच्छा diagnosis क्या है और अच्छा fluid है या नहीं है, and most of us don't really go beyond that कि अच्छा CSR है और अभी है या अभी resolve हो गया, diabetes में fluid कितना है, CNV में fluid है या नहीं है. So of course the presence of fluid is paramount in the evaluation of any OCT, but then there are things to go for which are far beyond. So we look at this diagram, this OCT, and we say, okay, so this is diabetic macular edema, CRT बढ़ गई, macular volume बढ़ गया, और इसको injections की ज़रूरत है. But if you look closer, there are so many things to evaluate within the same OCT. Not every diabetic macular edema OCT is the same, and you can get subtle hints and features on the OCT that tell you a lot more about what the patient is going through than just the fact that he's got edema. So I'm just going to be letting you observe. Now these OCTs are from my clinic, and you can see that there is a difference between the macular edema above and the macular edema below. There are very subtle differences that I'm going to be going through. So again, macular edema, diabetic macular edema, macular edema, but how is it different? Now, if you look at it here, ये मेरा काम कर रहा है. यहाँ पे आपको एक terminology जिसको we like to give fancy name to things, disorganization of the retinal inner layers. You see that the retinal inner layers are all fuzzy and indistinct. This is a sign of inner macular edema, inner macular ischemia. So when you've got a clear-cut OCT like here with well-defined inner layers, you know that this patient is going to respond better to your anti-VEGF. Don't try and make a lot of promises to this person over here, because the ischemic component is predominant in this case, although it will respond to anti-VEGF. But there is a lot more here that is going to compromise your final visual outcome. तो ऐसे केस को कहना चाहिए 3 टीके लगाएंगे बिल्कुल ठीक हो जाओगे आप लोग, 100% आपकी विजन वापस आ जाएगी. From day one, I know that this is not the case. Similarly, here, आप देखें कहीं पे outer retinal layers में break आ गई है, and at the same time, there's quite atrophy of the intervening septa between the cysts. So you can see that the cysts in this case and in this case are spanning almost all of the retinal layers. So this atrophy of intervening septa is actually atrophy of neuronal connections. So आपका न्यूरो रेटिनल टिश्यू है ना, so उसमें सारे जो बात है वो सब ये है कि लाइट को रिसीव करना है और इम्पल्सेस देने हैं, and for that there are a number of cells that play within these 9 layers that are interconnected and you have neuronal pathways. So atrophy of the septa structurally translate to loss of neuronal receptors, and therefore again a bad prognostic sign. Again here आप देख सकते हो कि यहाँ पे एक cyst बनी हुई है और cyst के अंदर जो है herniation हुई है hyperreflective intraretinal foci की, and when these configure themselves around the wall of the cyst we call this a pearl necklace sign because it looks like just a pearl necklace. ये सारी जो नुक्ते से हैं ये marginalize होके cysts को line दे देते हैं. That is a precursor for hard exudates. So if you've got the pearl necklace sign and you've got hyperreflective foci within the cysts, you know कि यहाँ पे in the long run hard exudate बनने लगे अगर ये patient treat नहीं होता. और अगर hard exudate is anywhere close to the foveal center like this, तो we all have been there where we've got central hard exudates जिनको आप जितने टीके लगा लें वो ठीक नहीं होते. They herniate into even the subretinal space. I'll be showing you a diagram on that. And then the hyperreflective intraretinal foci themselves, studies have shown that they are correlated to the HbA1c. यानी जितना पुअर ग्लाइसेमिक कंट्रोल होगा उतने आपको ये डॉट्स ज़्यादा नज़र आएंगे. Already you know that this patient has a lot to work on as far as systemic comorbidities are concerned, and you spend some time with the patient letting him know that just an anti-VEGF will not make a difference here. Again, we've seen DMEs, but sometimes we see them with the subretinal fluid. इसमें inflammatory component ज़्यादा होता है, and there are studies that show that this subretinal fluid responds better to steroid than to anti-VEGF. So if the onset you've got this person, Baba ji hai, pseudophakic hai, you might even just start with a steroid, especially if he's not affording either. And you know that you've got a better chance of the subretinal fluid kind of resolving itself with that. Okay. Again, subretinal exudation. Now I've actually had this published. This is a process that we've got in 3 different subjects with DME. और आप देखिएगा इसमें तीनों को अगर आप एग्रीगेट करके देखें, you can actually see dynamically that process of a hard exudate developing with subretinal fluid, developing an outer retinal break, herniating into the subretinal space, and then you end up with this kind of OCT चीज़ जिसमें आपको समझ नहीं आ रही होती कि डायबिटिक एडीमा में ये CNV कैसे बन गई है. This is not CNV. If you do an OCT angiography, you'll realize that there's no angio flow inside here. There's no blood flow. This is actually a hard exudate that is herniated into the subretinal space. अब इसको आप जो कर लें, ऊपर photoreceptor degeneration भी हो गई है और वो subretinal space, वो lipid जो है वो नीचे जाके deposit हो गया. This will not go away with anti-VEGF. So this, for me, I don't even try, right? So you have to realize that this person with a subfoveal subretinal hard exudate is not going anywhere as far as the vision is concerned. Then these sort of vitreous condensations on an OCT, this can kind of preclude the need for an FFA because this is actually a neovascular tissue. जो retinal neovessels होते हैं over the disc. So if you find this and you've got these little hyperreflective intraretinal foci, you know there's NVD, you know there's hemorrhage. Now what is the rationale behind getting a fluorescein angiography done? And most of these patients really have compromised renal profiles as well. So the use for fluorescein in them, if you can kind of save them from an FA just by looking at an OCT, then just go for PRP because you've seen new vessels and you've seen vitreous hemorrhage. And then taut posterior hyaloid membrane. We usually underestimate the importance of a taut posterior hyaloid membrane because this adds a mechanical component to your edema. And mechanical component as well does not do very well with anti-VEGF. So on 2-dimensional B scan, the taut posterior hyaloid membrane may look like this. But then if you do the same, view the same patient under a 3-dimensional view, that taut posterior hyaloid membrane is actually causing significant mechanical traction on the retina, and therefore makes it unlikely that this patient is going to respond to anti-VEGF. So all those signs of diabetic macular edema that we miss just by looking at CRT and macular volume. And there's something that if you just look at it a little deeper, then you realize that there's a lot more that you can catch out of the OCT. Now, of central serous retinopathies, there is something known as the Batman sign. All of us were fans of Marvel or Disney or whatever. This is a Batman sign, and it's usually an indicator that the CSR is very, very acute. because acute CSR में fibrinous element होता है within the cavity that is being formed. So it has these adhesions that's hard to let go of in an acute CSR. So you've actually caught it very early. Best to wait in this case. So not be alarmed by this kind of thing. And at the same time, you've got CSRs, usually इनकी अगर आप cavity में देखें तो आपको RPE irregularity मिलती है. Somewhere within the cavity of the CSR. Now studies have shown that this RPE irregularity actually corresponds to the point of leakage if you do an FFA. So again, we used to debate that FFA and OCT are not replaceable and substitutable investigations, they're complementary investigations, but there are elements in an OCT which can help you save the patient from an unnecessary investigation. So this will respond to the point of leakage, और हमारा जो macular laser chronic CSRs में करने का होता है उसमें सबसे बड़ा जो sort of hitch होती है वो यही होती है कि it should not be too close to the foveal center. In this case में you know that macular laser is probably not a good idea because already you can see that the point of irregularity is very close to the fovea. Again here, there's a very subtle point of irregularity and then that usually corresponds to leakage on an FFA. Chronic CSRs tend to present very differently on an OCT. So just by looking on an OCT, you can realize whether this patient has a recurrent chronic lesion or if it's an acute lesion. Chronic CSRs में आप देखेंगे कि outer retinal degeneration होना शुरू हो जाती है. So the more prolonged the CSR, the more the recurrence, you find that the outer retinal elements, the photoreceptor layers actually become degenerated. And sometimes all you see is this in presenting first presentation of the patient, and you're not able to figure out कि ये चीज़ क्या है. Patient presents with low vision, and you get this diagram. There's no sign of a CSR. This usually happens when he's got one good eye, and he's been neglecting the CSR in the other eye. वो आता रहता है और जाता रहता है, and eventually you find that there's a foveal atrophy, and there's no other sign of CSR at present. उसमें if you do a fluorescein angiography, autofluorescence, you will find that this very zone will correspond to the site of the CSR and it will be hyper-autofluorescent. So that is another sort of presentation altogether कि multimodal imaging को कैसे एक दूसरे के साथ net करना है. But for the purposes of this presentation, I was focusing basically on CSR. And then you've got, okay, ठीक है, RP irregularity भी मुझे नजर आ गई. In a patient with chronic CSR, be very, very mindful if this is not a developed CNV. So we know that chronic CSRs do develop CNV. They present to my clinic more often than I'd like to. And if you do a fluorescein, and for me, this is one of the very few true indications of getting an OCT angiography done. Because अगर इस पे आप fluorescein angiography करेंगे, तो you will get that submodeling hyperfluorescence leakage anyway of an active CSR. And it's hard to differentiate that between a chronic CSR and a CNV. So if you do OCT angiography on this lesion, you find out that there is in fact development of CNV in this lesion, and this to me is an indication for using anti-VEGF in CSR. Perhaps the only indication for using anti-VEGF in chronic CSR is when you've got documented evidence that there is a CNV in there. And then you have to be very mindful of atypical CSRs. So find there is a fluid under the fovea, find there is, but what you see is that there are a lot of intraretinal cystic spaces as well. That is not a typical CSR presentation. Typical CSR की pathology ही नहीं है कि वो intraretinal edema cause करेगा. So in which case you have to be very mindful. This is a typical, if there was a junior here, I would have gone up to the rest of the room and asked somebody to take a guess at what this is. This is an optic disc pit, and optic disc pit associated maculopathy. But this patient was referred to me for treatment for CSR. Again, be very mindful of a CSR जिसकी peripheral extent आपको नजर नहीं आ रही. And it does happen when you're running a retinal imaging center that a typical retinogenous retinal detachment will present to you like this. And we look at the central OCT and we say, अच्छा ठीक है CSR है, Epler दे दो. But only when you look at the fundus examination, find out he actually has a shallow RD. So when you can't see the peripheral extent of the CSR, do not diagnose CSR unless you've seen you've done a peripheral retinal examination. Choroidal neovascular membranes. We look at lesions like this on an OCT and you're almost sure that this is a CNV. But now we've got another investigation called OCT angiography with its brilliant OCT overlay. So the flow overlay is silent. There is absolutely no blood flow within this region. And that rules out CNV and actually does the diagnosis in favor of a vitelliform lesion. So CNVs never always necessarily look like CNV. This again looks like a type 2 CNV. It's a more sort of appropriate terminology to use is subretinal hyperreflective material. and this patient was actually subjected to anti-VEGF injections. But what they didn't notice was this hump underneath it. So this is actually a choroidal pathology with overlying SRF and subretinal hyperrefractive material, which was in fact not giving any angioflow on the OCTA. This later turned out to be a patient who was a known case of renal cell CA and had now had metastasis in the choroid. So the choroidal met was actually causing the fibrinous CSR on top, and it was being misdiagnosed as CNV. Again, when we did an OCTA, there was absolutely no flow within what seemed like a CNV, but it wasn't. So these are the different, when you've got fluid in a typical CNV, you have to analyze कि वो fluid किस level पे पड़ा हुआ है. आपके जो latest guidelines आ रही हैं वो तो ये कह रही हैं कि intraretinal cysts are absolutely intolerable. So if you see intraretinal cysts in CNV, then you have to treat until the IRCs are dry. But subretinal fluid to some extent may be tolerated, even especially if after 2 anti-VEGF injections on appropriate intervals, the SRF is stagnant. So if it's not going away, it's staying stagnant, so that is an indication for you to extend your treatment. Sub RPE fluid के बारे में अभी तक कोई clinical guideline हमारे पास CNV में आई नहीं है. This looks like a sub RPE fluid, but actually isn't. This is a lesion that we call prechoroidal cleft. And prechoroidal clefts are formed when you've got you've treated a person repeated with the anti-VEGF, और anti-VEGF जब shrinkage cause करता है तो वो जो CNV lesion है वो अपने size से shrink करती है, and it kind of gives away to this optically empty space, not to be mistaken for.
Can you repeat this? That's what you said.
The whole of it. Okay, so this is a CNV lesion, and apparently it looks ऊपर तो intraretinal cysts हैं, नीचे लग रहा है कि जैसा sub RPE fluid है, but sub RPE fluid, yeah, like optically empty space under the CNV lesion, not just right under the RPE, under the CNV lesion is actually a prechoroidal cleft. And that actually occurs and it develops because of repeated anti-VEGF injections causing shrinkage of the CNV.
Why is it called prechoroid? Because it seems to be in the choroid.
No, the choroid is underneath, it's
And above this lesion is what? This is the CNV?
So this is the CNV,
Okay.
that is the RPE. So it's actually sub-RPE CNV, which is type 1, and then this is the choroid. So since this is sort of anterior or above the choroid, it's called prechoroidal cleft, because it's not sub-RPE, it's actually prechoroid. And that is not to be mistaken, because it's actually an optically empty space, but not to be mistaken for fluid. You don't have to treat this patient unless he has intraretinal cyst, which in this case, the level here, for example, इस चीज़ को आप फिर भी सब RPE fluid कहेंगे, but वो जो CNV के नीचे पड़ी हुई optically empty space, that's not fluid.
So it can't be fluid.
It can't be fluid. It's most likely not fluid, especially in a case which is giving you a history of repeat. It's just shrinkage, lacuna, जैसा lacuna बनेगा होता है ना, वो it's not VEGF mediated and it's not leakage mediated. Of course, it's going to be filled with some sort of, it can't be air because air तो नहीं आ सकती. But the thing is that this is not a leaking CNV. More so it's because of repeated treatments with anti-VEGF. So it's a shrinking CNV.
Is there any way to confirm it whether this is a fluid or selective?
Well, I guess you can go for a fluorescein angiography, but fluorescein angiography in such advanced cases leads to staining at this area. So it makes it very difficult to differentiate between leakage and staining. And most of the time the margins will blur because it's such a chronic lesion. So it will be very difficult. I think the most likely giveaway of this prechoroidal cleft is its location right under the CNV.
And the fact that the patient has had repeated.
Yes, and the history. All right, so as I began my talk, I was talking to you about, you see so many OCTs and then one day you start to pick up patterns which are not been described previously. This to me was my case number 1, and at that time this was in 2000 and I think it was 16 or it was 2016. I shared this with one of my mentors abroad, OCT के जो वो है OCT reading center के, and he said I've never seen anything like this. And then after 3 weeks, the same thing came to me again. It's a filled-in appearance of the foveolar contour, जो उसकी concavity है. It appears filled in, but what differentiates this from an epiretinal membrane is that there's no surface wrinkling. And instead of the foveal contour getting obliterated as you would in vitreomacular tractions or epiretinal membranes, the foveal contour stays the same, and the overlying central hyaloid, the posterior hyaloid membrane, it appears to fill into the concavity, sort of like a kid has just colored in your foveal contour. I showed it to one person, they said, I haven't seen anything like it. Showed it to another person, they said, I didn't see anything like it. And these cases just kept on coming. Only in cases of very, very advanced choroidal neovascular membranes. Perhaps the reason why they had never seen it before, because हमारे यहाँ ये वाले लोग ज़्यादा जल्दी present, मतलब ज़्यादा often present करते हैं with such advanced fibrotic lesions. And eventually, more and more debate came along, and we started to collect cases like this. And this, I'm happy to say, has just been published in the American Journal of Ophthalmology as a novel OCT finding. We call this central posterior hyaloidal fibrosis. This term has been formulated by not just me, but also the likes of Brandon Lujan, Pierre Skeen, and Alistair Denniston, who are people that I've been working with. These 5 cases, in fact, there were 8, took us around 6 years to collect, and it took another 2 years to publish. But it's a novel OCT finding. Nobody's ever picked it up before, and we believe or theorize that it is because the underlying CNV has possibly got some pro-fibrotic influence to the overlying posterior hyaloid membrane. So it always happens in advanced CNVs, always happens in CNVs which have got attached posterior hyaloid to it. And we believe that there's somehow, because there's always that debate कि vitreomacular adhesion जो है वो CNV development को किसी तरह promote करता है. Although there are studies that negate that as well, there are other studies that found that vitreomacular adhesion अगर CNV develop कर ले तो release उसका rate हो जाता है. And somehow the other, the CNV makes it a little stickier. But with this case series, we're trying to theorize that it's not just the overlying VMA that is affecting the CNV, but it can be a bidirectional relationship where the CNV can also have an influence on the overlying hyaloid membrane. So, as I said, the more deeply you look into stuff, you find out that, there's stuff that you can't see.
Are you planning to send these patients to the VR?
We did get VR consults for some of them, but they were so fibrotic. I can send you the link. In fact, it's there in the Medical Retina Association of Pakistan's website. And when you see the fundus photographs associated with them, there's a lot of surface scarring. So, in fact, we didn't even offer them a medical therapy for that.
So I think probably me, if I have to go in, I wouldn't be over the phobia. What I'll do is I'll release the vitreomacular traction as the posterior and leave the fibrotic patch on the phobia. I think there is an element of EMT leading to those empty spaces as well within the retina. So if there is a visual potential, I think probably I'll be going in sooner. Lekin ye to sare jitne bhi hai, except the last one, I think the only top 3 ones before, the visual potential is not very
And plus, it doesn't seem to be exerting that much of a tangential traction anyway. I say that because of the lack of inner retinal surface wrinkling. So the evidence of tangential traction is on the OCT was minimal, I guess. So
these patients will not be undergoing intervention, surgical.
Yeah, these patients will not be going surgical intervention. These were 5 or I think 8 cases out of 6,000 OCTs, consecutive OCTs that came into my clinic. What we are saying is that this is rare to see, but it may be a more advanced case of a more frequent and more common underlying process, a pathophysiological process that we're just not yet picking up. So I thank you for your patient listening, and I'll welcome any questions.